So, lastly, we'll look at some of the other experimental drugs. Zilovertamab is what we call ROR1 drug antibody conjugate. The easiest way to think about it, it has an antibody and has a drug attached to it. The antibody will float, and when it binds to the cancer will eat the antibody and release the drug, and the drug is allowed to sort of do its effect. The drug, which is MMAE, as you see here in the box to the left, we cannot give you that drug alone. It has to be linked to an antibody, because if not, it's too toxic. So by directly delivering it to the cancer, it does allow us to safely give this medication and allow this medication to sort of exert some of its efficacy. If you look at the 17 patients with mantle cell lymphoma, there's an overall response rate of 53%. 2 patients did get a complete response. What we don't necessarily have at this point is how long the efficacy is in this patient population when they receive this medication. So again, something that I'll say, stay tuned and we'll see how it works out long term. So if we look at some of the other options with approval, this is only just to show you that we have other FDA approved drugs that we can use. But the key takeaway from this is most of these drugs do not work. So again, what we discussed previously to this will likely be your best option if you fall into the setting of a post-BTK sort of landscape. These drugs such as lenalidomide, bendamustine, rituximab, and cytarabine. Again, we talk more about bendamustine, bortezomib, temozolomide. These drugs, again, are not something that we typically would look to use in this post-BTK setting unless we have run out of other options. Now, briefly circling back to our early relapse high-risk patients. These patients we know have the very worst outcomes. These patients, if you can get to a CAR T center, you should go to a CAR T center. If not, you should be considered for a clinical trial. Standard of care options are generally not going to work very long. So again, CAR T or clinical trial, or if you're at a CAR T center and they have a clinical trial with a CAR T, all to move forward. So again, this is something that really should be taken to mind, that most standard treatments will not work very long in this patient population. So you need something different than what we typically can offer as far as chemotherapy or other sort of treatments we can give outside of those that utilize your immune system or other experimental treatments to work. So just summarizing this in general, in the post-BTK mantle cell lymphoma, it has historically been a difficult to treat patient population. Several older approved drugs with very little efficacy in this setting are present. Again, there are newer treatments that have come along that should actually improve outcomes. Again, CAR T with brexicaptogene, if you can get to a CAR T center. Pirtobrutinib was recently FDA approved. Again, with that agent, there is just maybe some question about how long the durability of that drug will work and whether it needs to just be used as a bridge to something else. Other agents as well with promise, but these are also currently limited to clinical trials. As I mentioned this several times during the presentation, if you have mantle cell lymphoma, you should ask about clinical trials and try to seek out clinical trials if you can, because that is likely to give you your best option for having a durable response in this treatment, in this disease. With that, I'd like to conclude my presentation and thank you for joining in. Thank you.